Hi guys, I'm starting with the cranial nerve 10, which is the vagus nerve. It's a mixed sensory and motor nerve. So let's start with the sensory first. So the first one is general somatic afferent, and afferent, as you know, it is sensory and it is somatic, so it's mainly conscious. It is general, so it is not a special senses. There's two different areas that you can see. One is the pharynx, larynx, and external ear. Concha is part of the external ear. So the receptors are located here, and the cell body is in the inferior vagal ganglion, and then it's not shown here properly, but that goes there and to the spinal trigeminal nucleus, which process mainly pain and temperature sensation. There is also receptors located in the posterior cranial fossa. The meninges are covering that area, so that again it is mainly pain in that area. The sensation of pain coming from that area. The cell body is located in the superior vagal ganglion, and that is connected to the spinal trigeminal nucleus. So this is the first order neuron, and this is the second order neuron, and from there it goes to the thalamus, and the thalamus is the third order neuron that's located there. As we talked about it before, VPM is getting sensory information from the face, and VPL is getting sensory information from the rest of the body. And from the thalamus, then it goes to the parietal lobe of the cerebrum, and then you can feel the sensation. So this another one is still we are in the sensory. So this is the next slide. So general visceral afferent. So this is from the organs. There's two different areas. One is the thoracic organs and the abdominal organs, and the sensory receptors are coming from there, and the cell body is located in the inferior vagal ganglion, and from there it goes to the solitary nucleus, which is located in the medulla oblongata. Because it is visceral, so that goes to the reticular formation, which is in the brainstem, and then it goes to the hypothalamus. There's other receptors located in the aortic arch, which is baroreceptors for pressure, for blood pressure, and chemoreceptors, which is important for giving information about the amount of oxygen and blood pH and carbon dioxide. So those receptors get information, and then it is going to the inferior vagal ganglion again. The information is not processed here, it's just getting information, and the cell body sends it to the solitary nucleus, and the solitary nucleus send information to reticular formation, and from there it goes to hypothalamus. So the same pattern is there, that sensory information from the visceral organs, so subconscious sensory information gets to the solitary nucleus, and from there it goes to the reticular formation and brainstem, and then to hypothalamus. So it does not go to the thalamus, because thalamus is for somatic sensory. The other part of the vagus nerve is the motor component. So this is a special visceral efferent. If you start here, the E is the efferent, so efferent is a descending pathway, which is motor, and the word visceral, which mainly mentions visceral organs, but in this case it's not actually the visceral organs, it is the embryonic origin of those organs, which is the pharyngeal arches. So the pharynx and larynx are originated from the pharyngeal arches, so that's why the name is a little bit different. So the one of the component of the motor is a special visceral efferent, which is supplying the pharyngeal and laryngeal muscles. These are the conscious motor activities, and it's coming from the cerebral cortex, from the frontal lobe. that goes to the nucleus ambiguous. So cerebral cortex is this upper motor neuron, and nucleus ambiguous is the lower motor neuron. And from there, these fibers goes to the pharynx and larynx, and the pharynx and larynx are responsible for swallowing, and larynx which is for production of voice or vocalization or a speech, whichever you call it. Another thing is, I just put it here in the box, is coughing and vomiting. So coughing and vomiting reflexes also are initiated in this area, in the pharyngeal and laryngeal areas. So nucleus ambiguous is carrying motor information, and it is connected with cranial nerve 5 and solitary nucleus, which they are getting sensory information. So all the reflexes has a sensory part and a motor part. So the motor part is provided by the vagus nerve, and the sensory part is provided by the trigeminal nerve, and also by cranial nerve 9, so glossopharyngeal nerve. The other part of the motor is general visceral efferent. So efferent again is the descending, which is the motor, and visceral is the organs here. So it's not a special, this is a general visceral efferent, which is the autonomic nervous system. If you remember, autonomic nervous system has sympathetic and parasympathetic, and here is the cranial nerve 10 is carrying parasympathetic innervation to the organs. So here is the thoracic and abdominal organs are receiving information from cranial nerve 10. So the nuclei are a little bit different. For the heart, the nucleus is nucleus ambiguous, and for the lungs and abdominal organs is the dorsal motor nucleus of vagus. So these two are the lower motor neurons, but upper motor neuron, it is at subconscious level, so it's not cortex of the brain, but it's some other areas. So the hypothalamus, mainly hypothalamus, and reticular formation is for most of the organs. Olfactory, which is part of the limbic system, that is for the gastrointestinal system. Nucleus solitarius, which are solitary nucleus, this is the one that receiving sensory information from different visceral organs. So in this case, the gastrointestinal system and the cardiovascular system are the important ones that are receiving information, and it is giving supply to these organs in the abdominal and the thoracic area of the body. The recurrent laryngeal nerve, if you look at this around here, so it is a part of the vagus nerve, one of the branches that goes under the aorta and going up, and that supplies the laryngeal area. And if that area is damaged, then the person is getting hoarseness, so hoarseness of the voice. The dysfunction of the cranial nerve 10 depends on the area that is involved. So dysphonia, this is the area for the larynx, that the person has a difficulty talking properly. Dyspnea, the P is usually not pronounced. This is shortness of breath, so the person has problem with diameter of the bronchi and the trachea, so this is why the person has difficulty breathing. Tachycardia is that normally the parasympathetic system is reducing cardiac activity, and if that is damaged, then the sympathetic system is taking over, and the person has shortness of breath. Dysphagia, because the esophagus is supplied by vagus nerve, and then if it's not working, the person has difficulty swallowing. And constipation is again the damage of the vagus nerve in the abdomen. Normally the parasympathetic system increasing gastrointestinal activity, and in this case vagus nerve is not working properly, and the person has constipation. Okay, so now is the cranial nerve 11, which is called accessory nerve. Accessory nerve is because it's not actually in the cranium. It's actually the nucleus for the cranial nerve is located in the spinal cord, and then the fibers are going up. So that's why it's called accessory nerve. It supplies two muscles. One is the trapezius muscle, and the other one is sternocleidomastoid muscle. So the cell bodies for both of them are located in the motor cortex. This is the upper motor neuron, and this is the conscious motor activity. So the fibers from upper motor neuron are coming down, but depends which muscle they go. Some of them are going ipsilateral, and some of them are crossing to the other side. So if the information is going to the sternocleidomastoid, it stays on the same side and supplying the sternocleidomastoid, which is this muscle, and this muscle is responsible for moving of the head and neck to the opposite side. For the trapezius muscle, so upper motor neuron is still located in the motor cortex in the frontal lobe, and then it crosses the midline and goes to the other side, and that supplies the trapezius muscle. So this is the trapezius muscle, and that is has different functions depending which part of it is contracting. If the upper part is contracting, it causes extension of the neck. If the middle part is contracting, it's causing elevation of the shoulder and the retraction of the shoulder, so moving the shoulder backward. And if the lower part is contracting, it causes depression or bringing down the shoulder. The lower motor neurons, this is the lower motor neurons, which is in the spinal accessory nucleus, and the fibers from here, it goes back through the foramen. It goes through foramen magnum, and from there it goes to the jugular foramen, and then goes and supplies sternocleidomastoid and trapezius muscles. By the way, cranial nerve 9 and 10 also pass through the jugular foramen. So if the cranial nerve 11 is damaged, then you can have two different tests. In this one, if you can see, the person is, you ask the patient to abduct the upper limb, and you can see that on the left side the patient is able to abduct, and on the right side the shoulder is a little bit lower. The main muscle for AB or abduction of the upper limb is deltoid, which is located around here. So this patient has some abduction, you can see it. Abduction is further away from the midline, but the shoulder, you can see the shoulder, the right shoulder should have been here, but it's a lot lower. So that's why this person has damage of the accessory nerve. If you look at this image, you can see that this person is being slapped on the right cheek, and also pinched on the neck on the other side. That's because this person was responsible for coronavirus. No, I'm just joking. I should not make these jokes anymore. The actual reason is because of the function of the sternocleidomastoid. This is the sternocleidomastoid muscle. So you find it and you palpate the muscle and ask the patient to contract. Once the patient contracts this muscle, the head moves to the opposite side. Now you put your face on the other side, so the face should move to the opposite side, and now you want to see the resistance against your hand. So if the patient can move against your hand, it means that muscle is working properly, and if it is not able to move to the opposite side, then it means that the nerve is damaged and the muscle is very weak. And hopefully the person is used hand sanitizer. So cranial nerve 12 is hypoglossal nerve, and this is a motor only nerve. So this is general somatic efferent. So efferent is again descending, which is motor, and it is somatic, which is conscious, and it is general. So the embryonic origin is not from the pharyngeal arches, but cranial nerve 11 is from the pharyngeal arches. So it supplies tongue muscles, so it's important for the movement of the tongue. The upper motor neuron is located in the cerebral cortex, and that is conscious. This is why it's important for tongue movements is important for the speech, and also for movement of the food to the side of the mouth, so for chewing. The lower motor neuron is located in hypoglossal nucleus, which is in the medulla oblongata, and then it passes through the hypoglossal canal. Hypoglossal canal is located in the occipital bone, and then it goes and supplies the intrinsic muscles of the tongue, which is these ones. The genioglossus muscle, which is this one, this is the genio of the mandible, and that is going toward the tongue. And the hyoglossus, this is the hyoid bone, and this is the hyoglossus muscle. And styloglossus, which is the styloid, it's not shown here. This is the styloid process of the temporal bone, and that goes here, and part of the tongue muscles. The genioglossus actually crossing the midline, the other ones do not cross the midline. So when you are assisting a person's cranial nerve 11, you ask the person to stick out his or her tongue, and you want to see if the tongue is in the midline or shifted to one side. So normally this is upper motor neuron, it crosses normally you should actually assess the genioglossus, because that is crossing the midline. So the other muscles is difficult to assess. So this is the cortex of the brain, and this is crossing the midline, and it is supplying the tongue muscles here. And if it is damaged, then the tongue is moving to the contralateral side. So this is an upper motor neuron damage. But in the lower motor neuron, when you see that the tongue movement is on the same side, it's on the same side. Upper motor neuron, the tongue movement is on the contralateral side. For the lower motor neuron, the tongue movement is on the ipsilateral side. And this slide is giving you a summary of all the cranial nerves, so it's a good thing to know. Cranial nerve 1 is called olfactory nerve, which is the sense of smell, and it is located in the nasal cavity, in the upper part of the nasal cavity, and it passes through the cribriform plate of ethmoid bone. Cranial nerve 2 is a special sense similar to cranial nerve. Both of them are special senses. So cranial nerve 2 is for vision, and cranial nerve 3 is oculomotor. Cranial nerve 4 is trochlear. Cranial nerve 6 is abducens. All three of these are motor, so that's important for the movement of the eye. Also, oculomotor has visceral efferent, so that is important for ciliary muscles and iris muscles. That is for when you see something close by, or if you if there's too much light, so the iris contracts, and that's also part of the oculomotor nerve. Cranial nerve 5 is trigeminal nerve, so it has 3 branches. It is sensory and motor. The sensory is on all 3 of them, 3 parts of the face, and the motor is only from the lower part of the face. So this is the upper part, this is ophthalmic, this is the maxillary, and this is the mandibular, and the motor is only for the mandibular. And the motor is for the muscles of mastication. Cranial nerve 7 is called the facial nerve, so it has sensory and motor. The sensory, the general sensory, is a small part in the ear. There is a special sensory, which is the anterior 2/3 of the tongue for the taste. The motor is 2 of them. One is a special visceral efferent, which is the muscles of facial expression, and also it's a general visceral efferent, which is the majority of the glands in the face except the parotid gland. Cranial nerve 8 is the vestibulocochlear nerve. It has 2 parts. One is from the vestibule and the semicircular canals, that is for the balance, and the other one is from the cochlea, which is for sense of hearing. So vestibulocochlear nerve is also a special sense. So you have the 3 special senses here. One is olfactory nerve, the other one is optic nerve, the third one is the vestibulocochlear nerve. So these 3 nerves do not have any motor, it's only a special sense. A glossopharyngeal nerve is cranial nerve 9. It has sensory and motor. For sensory, part of the external and middle ear, the posterior 1/3 of the tongue, and also pharyngeal area is supplied by this nerve. Also it has the general visceral afferent, which is around here. It's not shown here properly and that is for the carotid sinus and carotid body. The motor one is there's 2 of them. One is for parotid gland, so that is general visceral efferent, and another one is for special visceral efferent, is just one small muscle, that is for muscles of swallowing. Vagus nerve, which is cranial nerve 10, is a very long nerve. It is supplying from pharyngeal area all the way to the colon, so it is our large intestine, so it is a really long nerve. It is a mixed nerve, sensory and motor. It's for the sensory, it is receiving sensory information from pharynx, larynx, from the airways, from the cardiovascular, from the cardiac and bigger vessels here, and from the abdominal organs. And for the motor, it is that parasympathetic supply, starting from the pharynx and going all the way down to part of the large intestine. Cranial nerve 11 is accessory nerve, and it is motor only, and is supplying sternocleidomastoid and the trapezius muscles. And cranial nerve 12 is hypoglossal nerve, and that is also motor only, and it supplies the majority of the tongue muscles. There is one tongue muscle, is called palatoglossus, and that is not supplied by this nerve. Then this is the summary that is also in your textbook, so I do not want to go through this, and it's a good idea if you guys have a look at it. You can look at the name of the cranial nerve, and then the nucleus. A majority of these cranial nerves have more than one nucleus. Like some of them has only one, but majority of them, they have more than one nucleus, and depends on the function, the modality of them are a little bit different. So this is again is a review, it is nothing new. I already discussed this in the previous slide, so it's a good way that you can cover some of this area and try to guess which one it is. So it's a good practice, and if you don't know, you can go back and have a look at it.